You finally get a diagnosis for lichen sclerosus. And, for a brief moment, you probably feel this overwhelming sense of relief.
Oh, absolutely. Because you finally have an answer.
Right. You have a name for it. So you go to the pharmacy, you pick up your prescription, and you head home thinking like, okay, I've got the silver bullet.
Yeah, you think the hard part is over.
Exactly. But then you open the box of clobetasol ointment, you unfold that massive, manufacturer's leaflet, and the very first warning screams at you in bold text: do not apply to genital skin.
It's completely terrifying.
It really is. Suddenly you're sitting there wondering if the medical system is handing you a cure wrapped in this terrifying contradiction.
Right. I mean, it's a totally jarring moment.
Yep.
You're promised a resolution, but instead you're handed this piece of paper that makes you question whether your treatment is actually safe at all.
Yeah, like, are they trying to help me or hurt me?
Exactly. And the medical literature is incredibly comprehensive. But when you strip away the clinical context, it can just feel like you're being set up to fail.
Which is exactly why we're doing this custom-tailored deep dive for you today. Our mission is to completely demystify the side effects of steroid treatment for lichen sclerosus, or LS.
Because you need the real facts, not just the scary warning labels.
For sure. So to do that, we are cracking open a massive stack of sources. We've got the clinical guidelines from the British Association of Dermatologists.
That's the EAD.
Right, and the British Society for Pediatric Dermatology, plus patient instruction leaflets from Addenbrooke's Hospital, NHS medication guides, and this really comprehensive recent medical literature review on vulvar conditions.
That's a lot of material.
It is a ton, but we're going to separate the facts from the fear, figure out what actually happens to your body on these medications, and understand why the protocols are designed the way they are.
Because navigating a chronic condition is hard enough.
Yeah.
Without feeling like you're playing Russian roulette every time you open your medicine cabinet.
Oh, absolutely.
Having the full picture of the side effect profile really empowers you to take control of your own management process.
Okay, let's unpack this. We have to start by addressing that massive hurdle waiting right at the pharmacy counter. That generic warning leaflet that literally tells you not to put the medication on the exact place your doctor told you to put it.
Right. The infamous warning label paradox. I see this all the time.
So what is going on there?
Well, we're talking about ultra-potent topical corticosteroids here. Most commonly, clobetasol, propionate, 0.05%.
Which a lot of people just know by the brand name Dermovate.
Exactly, Dermovate. So that generic manufacturer's leaflet isn't a mistake. It's just written for a completely different audience.
Wait, what do you mean?
Well, it's designed for the general public who might be prescribed the cream for standard, run-of-the-mill dermatitis or minor rashes on their arms or legs.
Oh, okay. So just everyday skin stuff.
Right. And in those everyday scenarios, putting an ultra-potent steroid on highly vascular, very delicate genital tissue is a terrible idea. It would be way too strong.
But the clinical guidelines from the British Association of Dermatologists explicitly override that leaflet for LS patients.
They do, yes.
So what's the mechanism there? Why is the rulebook just thrown out the window for this specific condition?
Because lichen sclerosus is not a standard rash.
Right.
It's a severe, chronic, autoimmune inflammatory condition. Your immune system is actively attacking your own tissue.
Wow.
Yeah, and this leads to intense fibrosis, which is essentially an aggressive scarring process that completely remodels the tissue.
Remodels it. That sounds intense. What does that actually look like?
Well, you get severe architectural changes, like the resorption of the labia minora, narrowing of the vaginal opening, and that classic figure 8 pattern of pale, fragile skin around the vulva and the perianal area.
Oh, wow. So it literally changes the structure of your body.
It does. So you have to shut down that localized immune response immediately. And an ultra-potent steroid is literally the only tool heavy enough to do the job.
It's essentially like being handed a fire extinguisher to put out a blazing fire in your kitchen. But there's a giant factory sticker on the side of it that says, "Do not use on fires."
That is a perfect way to put it.
Right. You'd look at it and think, am I going to burn my house down if I pull this pin? But in this scenario, the severe inflammation is the fire, and the steroid is the chemical foam.
Exactly.
If you don't use it, the fire destroys the structure of the house, or, in this case, the vulvar architecture.
That analogy really hits the nail on the head. You need something overwhelmingly powerful to break that inflammatory cascade before the permanent structural damage occurs.
So it actually is safe.
Yes. The medicine is incredibly safe and highly effective for LS, even though that generic piece of paper heavily suggests otherwise.
Okay, but that fear of the warning label feeds right into the most common side effect patients stress about, right? Skin atrophy or skin thinning.
For sure. It's the #1 concern I hear.
And honestly, it makes logical sense to be afraid of it. If you're dealing with LS, your skin already feels incredibly fragile, like it's prone to tearing and fissuring.
Very much so.
And the NHS guide explicitly lists thinning skin, striae, which are stretch marks, right?
Yes, strutted marks.
And telangiectasia, those visible little blood vessels, as known side effects of long-term clobetasol use.
Right. Which brings us to a really fascinating medical paradox.
Ooh, I love a medical paradox. What is it?
Well, it is an absolute fact that ultra-potent steroids can thin healthy skin. They do this by inhibiting collagen synthesis.
Okay, so the warning isn't made up.
No, not at all. But here's the catch. Lichen sclerosus itself causes the skin to thin, tear, and break down because the chronic inflammation is destroying the tissue's integrity.
Right.
So when you apply an ultra-potent steroid to LS-affected skin, you aren't thinning it further. You're actually reversing the thinning.
I found this concept wild when reading the literature review.
It's pretty amazing, isn't it?
It is, because by halting the immune attack, the steroid gives the tissue a chance to actually rebuild its collagen network. It thickens the skin back to a more resilient state.
Exactly. It gives the body a chance to heal itself.
But wait, here's my practical pushback. If this ointment heals diseased skin but damages healthy skin, how on earth do you apply it safely down there?
That is the million-dollar question.
Right, because it's not like your body has a dotted line separating the affected tissue from the healthy tissue.
And that is the exact friction point for patients. It's why the clinical protocols from Addenbrooks and the BAD focus so heavily on application technique. You really can't just guess by feel.
So what do you do?
The guidelines dictate that you must use a mirror, and you have to visually identify that pale, diseased tissue and target it specifically.
Okay, so you have to actually look at what you're doing. And the dosing isn't just, rub a bunch on until it feels better.
No, not at all. Use the fingertip unit measurement, or FTU.
FTU.
Oh, yeah, this is a very calculated payload. Right. 1 FTU is the amount of ointment squeezed from the tip of an adult finger to the first joint crease.
Which is how much, roughly?
It equates to about 0.5 grams of ointment. Just half a gram.
That's tiny.
It is. You apply that half gram thinly, massaging it only into the active LS areas. If you stick to that strict protocol, you minimize the risk of the steroid creeping onto the healthy, unaffected skin where atrophy could actually occur.
So the whole narrative shifts completely. Skin thinning isn't some inevitable consequence of the drug. It's mostly a consequence of sloppy application.
Precisely.
If you color inside the lines, you're utilizing the medication as a tool for tissue restoration rather than something that breaks the tissue down.
Exactly. You're basically using a targeted strike to disarm the immune cells in that specific zip code.
Okay, so we've established that staying inside the lines protects the local tissue, but these are ultra-potent steroids.
Very potent, yes.
If I'm rubbing half a gram of Dermovate onto a highly vascular area, my immediate fear is that it isn't staying local at all, like that it's getting right into my bloodstream.
Which leads us right into the complexities of systemic absorption, and specifically the risk of hypothalamic pituitary axis suppression, or HPA suppression for short.
Yes, the literature spends a lot of time on HPA suppression.
Yeah.
Can we break down the mechanics of what's actually happening in the body there?
Absolutely. So your adrenal glands are responsible for producing essential hormones,
Right.
most notably cortisol.
Right, the stress hormone.
Right, which helps your body respond to stress, regulate your metabolism, and control blood pressure. Now, the hypothalamus in your brain constantly monitors your cortisol levels.
Like a thermostat.
Exactly like a thermostat. So if you introduce a massive amount of artificial, potent steroids into your bloodstream, your hypothalamus senses that flood and signals the adrenal glands to shut down production.
Oh, I see.
Yeah, it essentially puts your body's natural steroid factory to sleep because it thinks, hey, we have plenty in the system already.
And the danger isn't necessarily when the factory goes to sleep, right? But when you suddenly need it to wake up, like if you have a major physical trauma, a car accident, or surgery.
Right. If you face a severe stressor and your adrenal glands are dormant, your body can't produce the cortisol surge required to manage the shock.
Which is bad.
Very bad. That results in adrenal insufficiency, which is a life-threatening medical emergency.
Oh, yeah.
This is exactly why the UK National Patient Safety Alerts mandated steroid emergency cards for adults on high-dose steroids.
Oh.
So paramedics know immediately that a patient might crash without synthetic cortisol.
See, hearing about adrenal crisis and emergency responder cards is exactly the kind of thing that makes a patient want to throw the Dermovate straight in the trash.
I know, it sounds terrifying.
It does.
Yeah.
But the actual math here is crucial for putting your mind at ease. I looked at the thresholds in the literature review, and the gap between the danger zone and the LS treatment dosage is just staggering.
It really is. The math is incredibly reassuring. For an adult to realistically risk HPA suppression from a topical cream, they typically need to be applying 200 grams or more of an ultrapotent steroid to their body every single week.
200 grams a week.
Yeah.
Okay, to put that in perspective, how much is an LS patient using for their typical maintenance routine?
Well, if an LS patient is using the proper fingertip unit method, so that 0.5 grams roughly twice a week for maintenance, a single 30-gram tube of ointment should last them anywhere from 3 to 6 months.
That is wild. They're using maybe 1 or 2 grams a week compared to a danger threshold of 200 grams.
Exactly.
That means the standard LS protocol puts you at less than 1% of the systemic danger zone.
It's an incredibly tiny fraction, and the British Society for Pediatric Dermatology reinforces this too. They note that adrenal suppression from topical steroids is exceptionally rare in children when used properly.
Right.
They don't even recommend routine steroid emergency cards for kids managing localized skin conditions with topicals.
But if the systemic risk from the ointment itself is basically a rounding error, why is it such a prominent warning? Like, why do doctors even bring it up during the consultation?
Well, if we connect this to the bigger picture, the real risk of systemic absorption isn't about the LS ointment in isolation. It's about the cumulative physiological burden.
Ah, okay. The total amount across the board.
Right, your body doesn't compartmentalize where the steroids are coming from. If you were managing asthma with a steroid inhaler and maybe tackling seasonal allergies with a fluticasone nasal spray and taking an oral steroid for rheumatoid arthritis.
Oh, wow. Yeah, that adds up fast.
It does. And then you add the topical clobetasol on top of all that, your total systemic load obviously increases. Doctors have to calculate that combined cocktail across all routes of administration.
That is such an important distinction. It's the total steroid budget of your body.
Exactly. The budget.
So if you're using other steroid medications, you absolutely need to flag that for your dermatologist or gynecologist. But if Dermovate is the only steroid you're taking, your systemic risk is incredibly low.
Exactly. The medical consensus strongly affirms that clinically significant HPA suppression from LS topical maintenance alone is exceedingly rare.
Okay, so the systemic risk is essentially a math problem we can solve.
Yes.
But that doesn't invalidate the very real, immediate things happening on the surface of the skin when you apply this ointment. We need to talk about the local side effects. Because even if the math is in your favor, the physical experience can be brutal.
Yes. The day-to-day reality of applying the medication absolutely has its own hurdles. The most immediate one is stinging or burning upon application.
Yeah, that makes sense.
When your skin is actively inflamed, raw, and fissured from an LS flare, applying any ointment is going to hurt. Patients often report intense stinging that lasts for 1 to 2 hours after application.
Which is an awful catch-22. You have to rub something onto an open fissure to heal it, but doing so feels like rubbing alcohol on a paper cut.
It's highly uncomfortable. But there's a crucial clinical distinction patients need to make here. If that severe stinging doesn't subside, or if the skin becomes redder and more irritated after a few days of use, you might be dealing with contact dermatitis.
Oh, an allergic reaction.
Yes, an allergy. But usually not to the steroid itself. It's usually an allergy to the vehicle. So the inactive ingredients, the preservatives, or the base of the ointment.
So if it's constantly burning, you don't just push through the pain. You talk to your doctor about switching to a different brand or a different formulation.
Correct. Don't just suffer through it. Another major local issue stems from the medication's primary function. Because you are artificially suppressing the local immune response to stop the autoimmune attack, you are inadvertently rolling out the red carpet for opportunistic infections.
Right, because the immune system is turned down.
Exactly. The local tissue loses some of its ability to fight off environmental microbes, which means there's a significant risk of developing thrush or Candida yeast infection.
I can imagine how confusing that is for a patient. You're using the steroid to stop the LS itching, But the steroid triggers a yeast infection, which causes a completely different kind of itching.
It's incredibly frustrating. And it's why patients need to be hyper aware of changes in their symptoms.
What should they look out for?
If the nature of the itch changes, or if you notice a different kind of discharge, you shouldn't just aggressively increase the steroid application, thinking the LS is flaring. You need to get swabbed for a fungal infection and treat that concurrently.
Okay, good to know. But assuming you navigate the stinging, you avoid the allergies, and you dodge the yeast infections, the most complex local effect actually happens when you try to stop using the medicine.
Yes, stopping is tricky.
Here's where it gets really interesting, because the clinical guidelines treat stopping this medication like stepping off a moving treadmill.
I like that.
Right. If the treadmill is going 10 miles an hour and you just hit the emergency stop button and try to walk away, you're going to violently fly off the back.
You're going to crash.
You have to slowly dial down the speed. You have to taper. Why is the taper so biologically necessary?
It comes down to cellular adaptation. When you consistently apply an ultrapotent steroid, the drug penetrates the skin cells and actively suppresses the release of inflammatory cytokines.
Which are what?
They're the chemical messengers that cause inflammation. So over time, your cells adapt to this suppression. If you abruptly withdraw the steroid overnight, those cells experience a massive chemical vacuum.
Uh-oh.
Yeah, they hyperreact, drastically overproducing those inflammatory signals. Your tissue is suddenly flooded with a tsunami of inflammation.
And this is the rebound effect.
Yes, you experience a severe flare-up characterized by intense rebound redness, swelling, and burning. The tissue essentially throws a tantrum because the suppressor was yanked away way too quickly.
And I noticed a really critical clinical detail in the NHS guide about this rebound redness. It can be significantly more difficult to see on brown or black skin.
That is incredibly important to highlight.
It is such a vital piece of information, because a patient with darker skin might be experiencing the intense burning of a rebound flare, but because they don't see the classic bright red visual cue, they might not understand what's happening physiologically.
Right, that nuance in self-monitoring is essential. To avoid that cellular tsunami altogether, every major guideline from Addenbrooke's to the BAD insists on a strict tapering protocol.
How does the taper usually look?
Well, you might start by applying the ointment every night for 4 weeks to get the acute flare under control. Then you step the treadmill down to alternate nights for 4 weeks. Finally, you ease into a maintenance dose of twice a week. You are giving the cells time to adjust to the decreasing presence of the drug.
But the reality is, tapering requires patience, and patients are understandably terrified by everything we've just discussed. They read the generic leaflet, they worry about thinning skin, they hate the stinging, and they read about systemic absorption.
Yeah, it's completely overwhelming.
So they just want to stop. They abandon the treadmill entirely. Which brings us to the most dangerous phenomenon outlined in the medical literature review.
Steroid phobia.
Steroid phobia.
It is a pervasive, well-documented psychological hurdle in dermatology. Patients become so paralyzed by the potential side effects of the treatment that they engage in chronic undertreatment.
Like they just don't use it enough.
Right. They either stop the medication completely or they only apply it sporadically when the itching becomes absolutely unbearable, completely abandoning that twice-weekly maintenance protocol.
And we really need to highlight the stakes here, because the ultimate danger isn't the side effects of the medication. The ultimate danger is what the disease does when it's left to its own devices.
Yes.
Lichen sclerosus is progressive. If you let steroid phobia win, the chronic inflammation runs completely unchecked. So what does that unchecked state actually do to the tissue over time?
Locally, unchecked chronic inflammation leads to irreversible architectural destruction. That severe scarring process we discussed earlier just accelerates.
Oh.
The labia minora can literally melt away and resorb into the surrounding tissue. The structures can fuse together, which can completely bury the clitoris under dense scar tissue.
That sounds incredibly painful.
It causes extreme pain and drastically impacts sexual function. It can narrow the urinary opening, making it difficult to pass urine, and narrow the vaginal opening to the point where intimacy becomes literally impossible.
We're talking about permanent physical deformities resulting simply from avoiding the medication.
Yes, the anatomical changes are devastating. But the stakes get even higher at a cellular level.
How so?
Chronic, untreated inflammation acts like a cellular engine running dangerously hot. It produces a massive amount of toxic byproducts, leading to severe oxidative stress. Over years, that oxidative stress constantly damages the DNA of the localized skin cells.
And DNA damage is never good.
No. Chronic DNA damage is the exact biochemical pathway to cancer.
And the literature review quantifies this risk, and the numbers are just sobering. Patients with untreated or chronically undertreated LS face a 3.5% to 7% lifetime risk of developing invasive squamous cell carcinoma, vulvar cancer.
A 7% risk is highly significant in oncology, but, and here is where the clinical data offers incredible hope, patients who overcome their steroid phobia and remain highly compliant with their twice-weekly maintenance topical steroid treatment.
What happens with them?
They significantly reduce their risk of that architectural scarring, and they drastically lower their risk of developing vulvar cancer. The steroid doesn't just manage the itch, it actively protects the cellular integrity of the tissue.
Wow. So we have navigated an intense gauntlet of information today. Let's recap the reality of these sources.
Good idea.
The side effects of using ultra-potent steroids for lichen sclerosus are absolutely real. You might experience intense stinging when you first apply it. If you apply it haphazardly outside the lines without a mirror, you do risk thinning your healthy skin. You have to be vigilant about yeast infections. You have to calculate your cumulative systemic load if you use other steroid medications. And if you jump off the treatment treadmill too fast, you will trigger severe rebound flares.
But when you evaluate the medical evidence objectively, the risk-to-benefit ratio heavily favors treatment.
Heavily.
The amount of steroid you use for LS maintenance is a microscopic fraction of the systemic danger zone. And using that calculated 0.5 gram amount correctly doesn't destroy your tissue. It actually heals the thinning and tearing caused by the autoimmune response.
Having this knowledge doesn't just make you a quote-unquote compliant patient for your doctor's benefit, it empowers you to fiercely advocate for your own health.
Exactly.
You know exactly why you need a mirror, you know the science behind the fingertip unit, and you understand the cellular danger of stopping suddenly. Most importantly, you have the context to use this powerful medication safely, allowing you to avoid the truly devastating consequences of untreated LS, the irreversible scarring, and the undeniable cancer risk.
This raises an important question about the fundamental way the medical establishment communicates risk to patients in the first place.
It really does, and I want to leave you, the listener, with a lingering thought to mull over. Think back to that initial moment at the pharmacy counter. You open the box, you unfold that massive paper leaflet, and a generic warning screams at you not to apply the ointment to your genital skin, paralyzing you with fear.
Right.
If those standardized pharmacy warnings are actively fueling widespread steroid phobia, a fear so deeply rooted that it drives patients to abandon a highly effective treatment that literally prevents cancer and irreversible anatomical destruction, is our one-size-fits-all medical warning system actually doing more harm than good? Are we accidentally terrifying people away from the exact cure they need to protect their futures? It's definitely something to think about the next time you unfold one of those giant paper leaflets.
It perfectly illustrates the dangerous gap between simply reading a warning label and truly understanding the mechanics of a medicine.
That's all for this deep dive. Stay curious, keep asking all hard questions, and we'll see you next time.